10-month-old child, 2.5 birth weight, length is 72, and no other abnormality. Reasonably all right growth. Okay, right? Now your options are, show the options. Options are 1, A, B, C, D. Show all of the options. Yes. Could it be a GARD? Could it be a congenital cardiac defect? Could it be a congenital lung defect? Or could it be an atopic hyperreactive airway? Your time starts now. Fine. Let's see how the delegates have. Oh, unanimous GARD. All right. No, it's two-third, one-third. No, it's 50%, 25, 25. Yes, interesting, right? I think that's what we want to discuss. Each one of you may be right in your own way, and therefore, knowing this, majority felt it's a GRD. Nobody feels it's a cardiac defect. Few people felt it's a lung defect, and even further fewer also atopic. Uh, get back to the slide, please. Back to the slide. Fine. Now, I think Bhupendra, will
Yes,
you
sir.
pick up what is your thing and give reasons why others are not so right?
Yes, sir. So the 10-month-old child has persistent cough for last 4 months, and the growth is fairly good enough because the weight, being the birth weight of 2.5, now the 10-month, the weight is 7 kg. Length is also fairly good with no fever and no breathlessness. So this cough is of non-inflammatory type, and being the worse on feeding is telling us that something aspiration, either it is of small quantity or large quantity, but large quantity is not possible because it leads to sudden severe symptoms. So chronic small quantity aspirations, mainly GERD, is the possibility.
Fine. Malesh, do you have any option? Please
Yes,
make a
sir.
note.
Mostly
Yeah,
because in
yeah.
GRD, you have micro aspirations. You don't develop suddenly. It will gradually, especially during the feeding. And if other congenital cardiac defects and congenital lung disease would have developed with a failure to thrive, and the child is fairly all right with the weight. And since that is why we thought of GRD, more probably it is positive.
Fine. I think the case that I put up only because it looks obviously GRD, but there is a small differences. First is a GRD started at 6 months of age for the first time. Well, it could happen. Not that it has to start very early, I fully understand. But when there is an aspiration, it's often not totally a dry cough, though my both colleagues are right in saying that in a small infant, dry or wet cough is not easy to make out. Both look dry, okay? And therefore, you may have to ask more often whether there is some noisy feeling on the chest suggestive of a wet cough. And the other thing is that the cough is not varying in intensity or frequency. It's often worse on feeding. Therefore, there is always a feeling whether this was a typical GERD. Vomiting is occasional off and on, not all the time. And most important is, I have not said there is choking episodes.
Mhm.
Often when this goes on, there could be a choking episode. Show the answer, please. And therefore, this was a vascular ring. See, I, I am, I have chosen the type of cases which are a little out of the
Different.
box,
Yes.
but I'm sure that we are discussing with pediatrician, and I thought we should go at a little higher level than average practitioner, and therefore see how small little things could make a difference. But I must add one point here that in medicine, nobody can be sure. The first impression could be a GRD. Yes, right. And then you start analyzing. Now, more often now, when there is a D to GR, that is now GRD often there is a failure to thrive. And if it's going on for a long time, there is an esophagitis occurring. There is certainly failure to thrive to some extent, and the child often is irritable. No, these are small little things, but I'm sure everything. Don't think that I diagnosed this vascular ring suddenly. I made a mistake and I realized my mistake. Then I wanted to share with all of you, and that is what we are here. Can we have the next slide, please? Next case, please. Yes. Now, this is a 6-year-old child, little older now, presented with persistent cough since the age of 1 year. Take a note, started at around 5 years of age, and at times with fever, not always, lasting for 2 to 5 days. Fever lasting for that long in a 5 and 6-year-old child. Increasing frequency and duration of such episodes over the last 2 years. It started with repeated fever, cold, cough, whatever, but lately it is worsening. And last 1 year, this problem has been much in severe. That's how the patient has come to us. The next one, please. And he has been treated with antibiotics off and on. On physical examination, he was 17 kilos. His height was 105 centimeters. He's 6-year-old. His temperature was high, heart rate and respiratory rate were high, but look at the proportionate. Respiratory rate was a little higher proportionately to heart rate. There was no distress. Signs of pneumonia on right middle zone, plus there were bilateral crepitations also. Look at the examination very carefully. You have a localized signs and also generalized signs in bilateral crepitation. Your options are, show the options please. Could it be viral LRTI? Could it be partially treated bacterial infection? Could it be immune deficiency? Or could it be cystic fibrosis? Your time starts now. Well, we are fairly democratically good. I think majority feel it's a partially treated bacterial infection. Okay. But of course, all other possibilities are also considered by quite a few people, right? Can we go back to the slide, please? Back to the slide. Malesh, what do you think? Uh, how do you respond to those different bar diagrams? People have voted for each one of them.
So is viral LRTI is unlikely because the duration itself will rules out. It may not be a viral LRTI. Partially treated bacterial infections won't come back again and again, again and again, say 1 year, and that too it will causing a failure to thrive. And so either of the immunodeficiency or the cystic fibrosis. Among them, because the chronic disorder, there is a failure to thrive, there is a localization along with the bilateral creps are there. It's more involved one side and bilateral involvement is there. That is why it looks either of the like it is a general disease involving both the lungs, albeit causing more damage in the one side. That is why it could be more of is immunodeficiency or the cystic fibrosis. If it's immunodeficiency, would have other site infection also. Other than that, that's why it could be mostly cystic fibrosis. Only the age goes against because it started little later compared to the earlier size.
Very good. Dr. Bhupendra, any more thoughts on this?
Yes, sir. We need to dig out the history, how the child behave in between the episodes, and does it really the persistent cough, or the parents have considered that the child has continuous cough, but the child was fairly good in between the episodes. If it is so, then it can be viral LRTI because the frequency and duration has increased over last 2 years because the child has joined the preschools or now entered into the school. So because of frequent exposures to the viral cases, this child has developed viral LRTI, being that the signs of pneumonia on right middle zone and bilateral cracks. So it is mostly affecting the generalized airway disease, and virals are known for this kind, and the child's weight, height are absolutely fair enough with the 6 years old, and the fever has lasted only for 2 to 5 days only. So this is a normal child with in between recurrent exacerbations. So this child is having recurrent cough and cold in terms of viral LRTI.
Fine. I think both my colleagues have said that. Now, take a note of this. Repeated viral infections are very, very uncommon at this older child. Most often, it's a toddler who starts meeting with the community, and by the time they are 3, 4, 5 year old, their frequency of viral respiratory infections start going down, and therefore possibly this is not a viral. That's what Malay said. Now, partially treated also should have lingered on for a long time, so it's not so. So, like Malay said, either it's an immune deficiency or a cystic fibrosis. What I have not given much importance finding is I have not said anything about the stools. Had it been CF, I could have mentioned oily stools, but yes, I might have failed to mention that. So CF stand. But look at carefully. CF can manifest at any age. Yes, Malay said wide spectrum. And if this has been going on even earlier with some frequency, but last 1 year, worsening frequency of infection, then the weight would have fallen down much more. This child has done reasonably well, and therefore this turned out to be, show me the final answer. This turned out to be an IgA deficiency. Okay, and typical IgA starts with a toddler showing repeated viral infections, looks like. Some of them need antibiotics, but you ignore them. But the problems start worsening as the age advances. And I'm sure some of you must have seen also that first time they are picked up when a child develops ataxia. And then you look at the eyes and you have an ataxia telangiectasia, and then you go back and said, oh, I missed an IgA. Point to understand about IgA is that IgA deficiency is very, very common in the community, but it is a milder form of immune deficiency, and therefore quite a few get over it as your immunity of the other wings develops well, as against many other types of immune deficiencies which keep on posing you more and more problem. Again, the whole idea of this discussion is for every one of us, including me and both my colleagues, to learn more and more. And we never can stop learning, and we can learn from each other, one another. And that's the whole idea of this kind of a webinar. Let's go to the next case, please. Now, this is the child, a further older one. Okay, 15-year-old girl presented with a chronic cough for the last 4 months. No other symptoms. This was a dry cough, worse on exercise, and worse on deep inhalation. There was a hoarseness, there was a throat irritation, and also at times choking sensation. Make a note of all these small little things that I have given you. The next, please. And physical examination showed a stridor. Routine tests had no clue. Some therapy was tried, nothing worked. Now your options are, is it a habit cough? Is it a cough variant asthma? Is it chronic pharyngitis? Or it's really none of the above, something else? Your time starts now. Fine, let's get back to the slide, please. Upendra, many of these people have said it's a cough variant asthma. Now, how do you look at these four options?
Okay, sir, a 15-year-old child has presented with dry cough, which is worse on exercise and deep inhalation. And there is hoarseness, throat irritation, choking sensation, all tells us that it is upper respiratory because the physical examination also tells us that a stridor is there and routine tests have no clue with failed trial of therapy of antibiotics and all. So I think this is none of the above because the cough variant asthma, chronic pharyngitis, these are all not likely because pharyngitis has some kind of dry hacking cough, but which is not worse on exercise and deep inhalation. And it is not associated with choking as well as stridor. So the option left behind is none of the above.
Very good. Malesh, your thoughts on none of the above. I'm sure we all agree what Bhupendra said. Uh, Malesh, what do you think? What could be none of the above, right?
Yes, sir. Like because it stridor telling upper respiratory infection, that stridor is not caused by any of the above things, sir. And it could be that is why. And habit cough usually disappears in the night. It doesn't want to cough in the daytime. It won't be there in the only be there in the night time, daytime. That is that also. Cough variant asthma usually varies, sir. It won't become in the only on the fixed time continuously. It will be more on the night, and yes, definitely it will be more on the inhalation or the deep inhalation or the exercise, but it won't have other future like stridor and other things. Pharyngitis again, it won't go for about 4 months and don't have a stridor and other things. That is why it mostly none of the above could be a laryngeal area anatomical problems.
Excellent. See, there is a hoarseness. So it's not only upper airway, but it's a larynx.
Yes, sir.
Okay. And it doesn't seem to be a kind of an uh, progressive disorder. It stays on. Okay. And I just wanted to bring again a little different types of cases because that's where we will learn more. And show me the answer, please. This was a vocal cord dysfunction. Often we read in books a vocal cord dysfunction may simulate many things like an asthma, like upper airway obstruction. And this is a condition where when a child takes a deep inhalation, instead of opening up the larynx, the vocal cords come together and obstructs the inflow. This is supposed to be due to largely some stress induced or emotionally induced, and one rarely sees this, but I thought again this webinar is not for routine things, but see how both of our colleagues clearly said that first three are not likely at all, and they gave reasons. Okay, and we keep in mind such things seen often at an adolescent age, and possibly it's difficult to treat, but largely it's kind of a therapy to strengthen the mind, to get over the stress. All this is very, very difficult. I have not had any such uh, easy management of thing, and I even don't know when I send them to an expert. How can anybody easily get rid of your stress and anxiety? I wonder. We are not specialized in that, but somewhere we may end up with this without pursuing some therapeutic models, trials, or further investigations like a CT, etc. Very good. Let's have the next case, please. Now, this is a 10-year-old who presented with persistent cough for last 3 months. Started with self-limiting viral infection, but cough continued. It's a wet cough, no variability, often nocturnal, but no variability. No past personal or family history of cough. Next, please. And examination shows NAD. I often say NAD stands for two things, not no abnormality detected, but often in hurried clinical practice, those who have a lot of practice, NAD stands for not actually done. Examination not done at all. So, but this is really true NAD, right? Your options are now, show the options please. Could it be post-viral hyperreactive airway disease? Could be pulmonary tuberculosis? Could be chronic bronchitis? Or could be bronchiectasis? Your time starts now. Good. Let's get back to the slide, please. Malesh, first your thought on this.
It's unlike to be post-viral, sir. Though 10% of the viral, usually they last for 3 weeks, but 10% can go for about 2 or more than that, 6 weeks or 8 weeks. But it is 3 months or 12 weeks. Pulmonary tuberculosis, unlike because there is no much fever, cough is more than the tuberculosis. Very rarely, only and except for few conditions, tuberculosis, cough will be main symptom. Fever is there, weight loss will be there. Chronic bronchitis, less chances in the children's. It looks like a bronchiectasis that also you can come more in the night when they sleep and secretion collects more, and they have a because there is no personal history, a family history. It is unlikely that it is a HRAD or the family history of asthma. It is not related to asthma. For me, it looks like more of bronchiectasis, sir.
Fine. Uh, Dr. Kapadia, Bhupendra,
Yes,
you have
sir.
any
Yes, sir.
additional
I also go with Dr. Mallesh, sir, that it looks like a bronchiectasis because post-viral is usually dry cough, pulmonary TB, not likely because initially it has started with self-limiting and there is no fever at all. And chronic bronchitis in this age, less likely. And wet cough, bronchiectasis, yes, possible.
fine? The only small difference is this bronchiectasis has developed within 3 months.
Mm.
Now, bronchiectasis takes a long time to develop unless it's a congenital bronchiectasis,
Mm.
and in that case, it presents often as an acute bacterial infections which keep on coming again and again. And therefore, I just wanted to bring out another kind of a disorder that we often have to keep in mind. Will you show the answer, please? This was a protracted bacterial bronchitis. Okay, starts with some fever. Fever often disappears. The bacterial bronchitis continues. Looks like an asthma, but there is no variability. And we rarely see in pediatric practice chronic bronchitis. Chronic bronchitis is seen in adults with chronic bronchitis and emphysema. We don't see them, but I'm sure in the last decade, people are talking about protracted bacterial bronchitis. It's not an easy diagnosis. Possibly a diagnosis has to be further investigated in terms of picking up an organism, maybe a bronchoscopy. But the point is, what looks like a cough variant asthma like syndrome, but starts with fever, fever disappears quickly, chronic cough continues, and such children may need amoxicillin for 4 or 6 weeks to get out of protracted bacterial bronchitis. Again, trying to bring you cases which I have seen, heard, missed, and learnt. And I think that is what we are sharing on this platform. Can we have the next case, please? Now, this is an 8-year-old child who presented with persistent mild cough for the last 4 months. Make a note, the cough is mild and feeling tired for 2 months, but there has been no fever. Again, take every part of this statement very, very cautiously. Next, please. Next, please. Physical examination showed child is significantly pale. His heart rate is 100 per minute. respiratory rate is 25, there is no clubbing. Otherwise, there are no findings of any other kind. Here is there for a child with a mild cough. Start thinking about the microanatomy of mild cough. Only for last 4 months, feeling tired, pallor, significant pallor, but no fever. Your options are options miliary tuberculosis, histiocytosis, Hodgkin's lymphoma, or interstitial lung disease. Your time starts now. Fine. Get back to the slide, please. Bhupendra, what do you think about this?
So, sir, miliary tuberculosis is less likely because this child has no fever at all and the cough is very mild and no other symptoms of that. And histiocytosis, yes, it can be. And Hodgkin's lymphoma, no other symptoms seen in the case. Interstitial lung disease, yes, it can be because the persistent mild cough and feeling tired, it leads to respiratory dysfunction and it is gradually progressive. So over a period of 2 months after developing since last 4 months, now after 2 months, child has become breathless. So means child is becoming tired and the pallor is also there. So it can be either histiocytosis and interstitial lung disease. We need to have more investigations to rule out.
Malesh, your thoughts on this?
So the 8-year child with a mild persistent cough for 4 months, that tells that it is a chronic disease, not acute disease. And mild cough, it tells that it is a minor airways are involved, not the upper airways are involved. And tired and feelingness can be either in this condition because it is interstitial disease because of oxygen perfusion can be less, or it can be due to because of anemia. And that is why the miliary tuberculosis, unlikely histiocytosis, can be because it causes anemia plus and interstitial lung disease. It can be interstitial lung disease also, sir. Other than this, I think pulmonary hemosiderosis can present like this, sir, like with the anemia, with the interstitial lung disease. But it is a flappy bigger shadow, sorry, sir.
Excellent, Malesh. Okay, you gave a final diagnosis. Show the diagnosis, please. Pulmonary hemosiderosis. The point is, a chronic interstitial lung disease in general starts showing tiredness over time. And he is not very significantly pale. Okay, yes, both my colleagues said it's an interstitial lung disease. After all, this is interstitial lung disease. But when you saw significant pallor, that means he's losing blood somewhere. Now, Malesh put those two together and it called it pulmonary hemosiderosis. So fine. Uh, Bhupendra rightly said you need further investigation. For example, he could have picked up by bronchoscopy some blood elements there and would have picked up. Histiocytosis generally is not very localized for a long time. We could have had hepatosplenomegaly, uh, lymph node, etc. But a good thought. Okay. And therefore, histiocytosis also may not have been very pale, and that pallor puts us to possibly a diagnosis of pulmonary hemosiderosis. Good. Can we have the next case, please? Next case. Now, this is a 10-year-old who presented with persistent dry cough for last 2 months, urticarial skin rash for a month, and fever for a week. Look the sequence of events. This patient comes with dry cough for 2 months. 1 month later, he develops some urticarial skin rash, which goes on for another month. And finally, he gets fever for a week. Cough continues, rash continues, fever adds. Next, please. Physical examination shows chest is clear. There is urticaria. There were no other findings. Routine tests, no clue. trial with therapy failed, take a note of all this sequence of events. If you were in the first 1 month, you would have only cough. If you are in the second month, there was no fever, but cough and skin rash. And you were the last week, you had also fever. Look at the sequence. Your options are show the options: interstitial lung disease, asthma with secondary infection, pulmonary tuberculosis with drug allergy, or none of the above. Your time starts now. Back to the slide. Malish, your views on this?
The 10-year child with persistent dry cough for the last 2 months means it has a chronic cough for about 2 months. Articular skin rash for a month means it is allergic, probably allergic etiology, and fever for a last 1 week. It can be fever can be a part of arterial skin rash because it's inflammation. Arterial itself many times can cause fever, or it can be infection also. With all that, it looks interstitial lung disease looks unlikely because it will go long and have a hypoxia and failure to the other things. Sir, asthma developing urticaria after this phase is unlikely. That with secondary infection urticaria, pulmonary tuberculosis obviously usually have a long history and there is a fever and failure truth. It is not there, sir. It looks like most none of the above. Sir. It doesn't fit with any of these three conditions.
Absolutely. Okay, Bhupendra, any thought what could be none of the above?
Sir, ultimately a dry cough for last 2 months with urticaria and fever for a week. So it is immune mediated. Most likely it is immune mediated because the chest is clear and the urticaria is also there. So and no other findings are there. So it is immune mediated cough most likely.
Excellent. I think both my colleagues have exactly discussed correctly. Now, you look at the whole syndrome. A dry cough for first 1 month only, upper airway, and lasting for a long time, now develops allergy. So that allergy must be to a disease that started with a dry cough. Both of you said allergy, immune mediated. But finally, he starts fever. So it's an immune inflammatory disorder which starts with only dry cough, upper airway, and therefore, show the answer please. This was a Hodgkin's lymphoma. Now look at the Nelson textbook. It says Hodgkin lymphoma may start with urticarial rash. Okay, so this was a lymph node which was pressing the upper airway, starting with dry cough, then developed an immune mediated allergic disorder, and finally also had fever. But good thought, both my colleagues gave very clearly. Yes? Can I have the next slide, please? Next case, a 3-year-old presented with persistent dry cough for last 4 months. It started suddenly without choking. There is a past history of ear infections on a few occasions, but no discharge. Take a note. Sudden onset, but no choking. And 3-year-old, lasting for 4 months, a dry cough. And some infections, ear infections in the last few times. Next, please. NAD, physical examination. Show the options. The options are chronic rhinosinusitis, chronic pharyngitis, ciliary dyskinesia, or none of the above. Your time starts now. Back to the slide. Bhupendra, what do you think?
Yes,
What's
sir.
your
So here the child has come with dry cough and since last 4 months with suddenly without any choking. So it can be because of the obstruction at the upper airway and because the and as if the cough started suddenly, so it can be mechanical, allergic, vascular or neurogenic. But considering the history, it looks like mechanical because the history of repeated ear infection is also there, but there is no discharge. So this child with chronic rhinosinusitis, chronic pharyngitis, ciliary dyskinesia, and none of the above, the child fits more into the chronic rhinosinusitis, mainly the adenoiditis.
Malesh, your thoughts on rhinosinusitis?
Sir, mostly I'll go with Bhupendra sir. Sir looks like more of chronic rhinosinusitis, and the only thing why is there is suddenly onset. It is difficult to explain why a sudden onset of cough in chronic rhinosinusitis.
So good to make a point. Okay. First is rhinosinusitis is a complication of rhinitis. And in this child, there is no rhinitis. And Palesh said it's an acute onset. Okay. This baffled me completely. Okay. But somebody cured him without knowledge. And that was an ENT specialist. They went to ENT specialist to show whether why there is a recurrent infection, and there was no pus. So he knew that it was an otitis externa, and all that he found was there was a foreign body stuck to the eardrum, and that was the cause of cough. Show the answer, please. Foreign body in the ear. All of us missed. And the ENT man also did not know that he had cured cough. And the patient came back to me and said, Sir, अचानक कफ बंद हो गया. I said, क्या किया? He said, कुछ नहीं किया, वो ENT ने साफ किया. Okay, what a thing to miss, right? I will never forget this. Okay, and the last case. Next case, please. This is a 14-year-old presented with dry cough off and on for last 3 months. Bouts of cough lasting for 10 to 30 minutes with normal intervening period, no fever at all. Next, please. NAD. Okay. Options: chronic pharyngitis, hyperreactive airway disease, pertussis, or none of the above. Your time starts now. Fine. Back to the slide. Malish,
Yes, sir. In a 14-year child with a dry cough for last 3 months, what notable feature is the bouts of cough for lasting for about 10 to 13 minutes with absolutely normal in between. With that in feature, it doesn't look like chronic pharyngitis. It can be hyperreactive, but it is unlike because it only comes in the in between child is absolutely normal. That's why it could be a pertussis. Only thing I want to know the history, family history is there or what is there or history is there and whether it disappears during sleep. And another thing, it could be none of the above, sorry, either of the two, my son.
absolutely. Uh, Bhupendra, any idea what could be none of the above?
Habit cough is one of the possibility. We need to ask detailed history that whether this child is coughing at night or not at all. If it is not so, then it is the symptom of convenience that whenever the child wants, he starts this kind of cough. So habit cough is one of, I think that is the possibility.
Excellent, Bhupendra. Fine. I did not want to give that he sleeps well, but you asked the question and show me the answer, please. This was a habit cough. Okay. But the point is, what this webinar showed me that both my colleagues gave a very good rational approach to all these little out of the box cases. So I congratulate both of them. Okay. The whole idea was to share what I learned after my mistakes and for every one of us to make mistake so that we don't do the mistake again. But next time, don't start looking at the ear for a chronic cough. I'm sure all of understand. Uh, and uh, with that, next slide, please.
Sir, I think there is one more case.
Okay, yeah, but do we have time?
Yes, yes.
Yes, sir.
Fine, fine. Then show this case also. This was a 6-month-old infant who presented with cough, irritability, poor feeding for last 1 month. Make a note, only for last 1 month. No fever, family history of asthma and also TB contact. Next, please. Physical examination largely was normal. CBC was normal. Chest X-ray was normal. Okay. Your options are atopic HRD, pulmonary TB, consider CT chest, GRD, or an interstitial lung disease. Your time starts now. Back to the slide. Malesh, what do you think about this?
Is quite a young child, 6-month child, sir. The irritability and poor feeding last 1 month and no fever. It looks as it's unlikely to be infectious origin, maybe inflammatory and other reason. Family history of asthma and TB is there. With that consideration, it looks like unlikely to be atopic HRD is very rare to start with that age, young age, sir. Like that is why it will be pulmonary TB. If there is no much fever, that is why that's also ruled out. It could be a GERD or it can be a interstitial lung disease, sir.
All right. Bhupendra, any thoughts on this?
Sir, this child has cough since last 1 month with irritability, poor feeding, and family history of asthma. But here the HRAD is not likely because the atopic wheeze and asthma starts little bit later, and TB contact is there. Being an infant, child is not able to mount the that much inflammation, so there no fever. So in this child, we need to investigate further because child has cough with poor feeding. So we need to investigate. That is, it can be a pulmonary TB. We need to consider CT chest.
Fine. I think the point is this child again started only 1 month ago. Now, there's no reason why GRD doesn't start at that age for the first time, but this looks like a progressive disorder. There is poor feeding. Okay, so considering progressive disorder over last 1 month in an infant, and there is a contact with TB, in infant of disseminated tuberculosis or any kind of tuberculosis may not have necessarily fever as a manifestation. As such, you have a low grade fever, and an infant may not even respond to that. So, because there was no clue, we requested a bronchoscopy and show the findings, please, and uh, show the answer. It was an endobronchial tuberculosis in an infant. Upendra, you said that. All right. I think, show me the next slide, please, because I have some questions to my colleagues who have done so wonderfully well. Uh, we know that there is a specific therapy for etiology, but majority of cases that we discussed had no specific easy to go diet. Okay. So many times we have to use symptomatic treatment in the absence. Next, please. So now medical science says cough remedies are ineffective. Pharmacologists said there is no cough syrup. Okay. And many people said just give plenty of hydration. Okay. Local hydration, inhalation, steam. But for you and me, who are concerned with relieving cough and not only following science. Yes, scientific principles to relieve the patient and not science alone, let the patient cough.
Suffer.
That is not possible. So I am sure that art of medicine is save life and relieve suffering and following scientific principles, but not extreme scientific principles because you need relief. So my question to both of you, Malesh, you
Yes.
tell me, do you use cough syrups or not? Okay, I use cough syrup. Okay, now how do you choose what cough syrup and how long?
If child you think this is bronchospasmic
No,
cough,
we are not
then
asking only this child. In
yes, sir.
general, cough syrups.
I use, if you have bronchospasmic cough, you'll use a bronchodilator, sir. If it is a dry cough, hacking cough, disturbing the parents, I will give SOS cough syrup, so especially in the night, sir. That is why that time they will pursue the more cough. Though it is there in daytime, but they don't pursue because they will pursue more night. I'll give an SOS cough suppressant with a required dose only during the night, especially, sir. If it is
So,
needed, if it is strict.
Malesh definitely made it clear that you are not treating cough, you are making the child comfortable. And he said that most of the children cough through the day happily. They continue to play. Okay. But night the sleep is disturbed and thereafter the sleep is disturbed for parents. The next day the child is irritable. So we have to ensure good sleep for a coughing child. And that's what he said. Bhupendra, any more thoughts on this?
Yes, sir. In less than 6 months, we try to avoid cough syrups and we should use saline nasal drops so that the child remains comfortable. And in more than 6 months, we follow the same advice as Dr. Malli said that we need to alleviate the symptoms when they are much more significant. And if child is playing and doing routine activity, then we need not to treat such cough.
So clear. I think we have a clear message. Even I use similar thing. Fortunately, less than 6 months, we rarely face a problem of chronic cough, and thereafter, judicious use. And both my colleagues said only SOS, only at night. The next slide, please. Next thing. So relieve discomfort of coughing with judicious use of drug. Next, please. Bronchodilators, Malay said spasmodic cough, use that. You may use cough sedative, not codeine, but maybe dextromethorphan. You might like an antihistamine SOS, which can put the child to sleep. Mucolytics expectorants are rarely required because our children don't have lot of ability to put up a. The next, please. Next, take home messages. Chronic cough lasting for more than 8 weeks. A diagnostic therapeutic challenge. That's what we discussed today. The next, please. Must suspect chronic cough early in the course of events. Next, please. Next, please. Early diagnosis leads to rational investigations and therapy. Tests are not to search the diagnosis, but rule in or rule out provisional clinical diagnosis. We see but not observe. We hear but not listen. We know but not think. So follow steer concept. The next, relieve suffering while trying to cure the disease. Next, please. Next, please.
That's all, sir.
Yeah. And at the end of this webinar, I'm so happy to have both my colleagues who did extremely well, gave us a lot of pearls of wisdom, and I congratulate both Upendra and Malesh. Thank you very much, both of you, for agreeing to be on live with me. And thank you all the delegates who also joined us. Back to Dr. Pal.
Yes,
Thank you, sir.
thank you, sir, for this deeply insightful session. I think we have a few questions from the audience's end, if we can discuss.
Yes, uh, you can ask one of the two alternately. Okay?
Yes, yes.
Yes, please.
So, the first question is, what specific warning signs in chronic cough should make us think of serious conditions like interstitial lung disease or immune-related problems?
Yeah, Malesh.
Yes, sir. One thing is usually it is a chronic cough and chronic disorder. Most of the time they have a failure to thrive and they have a recurrent infection and they have a weakness and tiredness many times because of hypoxia, decreased oxygen fusion. And with this picture, you can think of these conditions, sir. Sir, muted, sir.
I think, sir, you are on mute, sir.
I am on. I am not. Somebody else has
Yes.
muted me.
Yes,
Maybe.
yes.
So, what Malesh emphasized, what a slowly progressive disorder with hypoxia as a manifestation is an interstitial lung disease. Okay, and with minimal cough. So clear, right? Sir, next question.
Yes, so the next question is, how can we tell if a child's cough is just post-viral or if it's truly of unknown cause needing further investigation and tests?
Yeah, Dr.
Yes,
Bhupendra.
sir. Yes, sir. So viral cough, they are associated with high degree of fever, and some or other family member is usually affected, and simultaneously or say 7 days before or something like that, and the child remains absolutely normal in between the episodes, and usually the viral fever, viral cough usually lasts nearly 7 to 10 days, and in very few cases it lasts for 10 to 15 days. That's it, but it does not leads to chronic cough in general.
I
Sir,
think, sir, you're on mute again.
S- Sir, I always tell sir one system, multiple system in a single person, multiple persons in a family, multiple family in the community. Unless otherwise proves it is a viral.
Sir, I think you
Okay.
should mute and unmute once. There is some problem with the microphone.
Okay, okay,
Yeah, right now we can hear you.
okay. Next question.
Yes, I think the last question is, in places with limited resources and settings, how do we decide when to just observe a child with chronic cough and when to do detailed investigations?
Well, I think Malesh first and then also Dr. Kapadia, because this is an important question. Malesh,
Yes, sir. The abused child, if it is has a failure to thrive and started quite early in the life, like for example, around 6 months, because it may be congenital and then it has progressed afterwards. And there is a sibling death in the family. So some similar complaints are there in the family, and there is associated severe symptoms like what is called productive cough, clubbing is there, and not responded to routine treatment. This all you have to think that it is unlikely to be a simple cough, and then you have to work out extensively in other investigation and refer to the consultant.
very good.
and
Bhupendra,
I would like to add here that in whether it is resource limited setting or resource rich setting, we have to focus on history. We need to dig out the complete origin, duration, and progress. So, in majority of the time, we will be able to reach, at least we will be able to narrow down the possibilities, and thereby we will be able to avoid lot of investigations.
Sir, I
I
think you
must
should.
say that I
Yeah.
must say that resources can be found today. No poor patient should fail to be diagnosed because there are no resources. We must try to achieve a final diagnosis every time. And I think today there are possibilities, general hospitals, all that. Well, I think we had a wonderful session. Back to Anupam, back to Dr. Pal.
Yes, yes, yes. Thank you so much, sir, for answering these questions. So I think we can conclude today's session, and my heartfelt thanks to Dr. Amdekar, sir, for his invaluable insights for today's session, and to our distinguished panelists, Dr. Kapadia and Dr. Gowda, for the valuable perspectives on today's topic. Yes. So thank you all for joining us today, and maybe take these learnings into our practice to make every decision more thoughtful and more patient-centered in the long run. So the topic for our next episode on this case-based webinar discussion series is diagnostic challenges in vomiting. Yes. So we will be shortly announcing the date for this. Till then, let's stay curious, stay compassionate, and above all, stay clinical. So this is Dr. Amit Pal signing off. Thank you, everyone, and have a very good
Thank you,
day.
sir. Thank you, sir.
Thank you so much.
Thank
Thank you, sir. Thank you, Dr.
Thank you, sir.
Thank you, Amdekar, sir.
Dr. Malesh. Thank you, Dr.
Thank you, sir. Kapade, sir. Thank
thank
you.
you.
Namaskar.
Thank you, everyone.